Lovely. Super. So, hello everyone, and welcome to our final webinar in our series of winter webinars hosted by us here in the Irish Society for Disability and Oral Health. I'm delighted to bring to you this evening a topic which hasn't recently been covered by the ISDH actually, and judging by the registration numbers, it's a topic that many of us want to hear about. So I have to thank Neil Martin for finding such fantastic speakers this evening, and also Kin Dental for sponsoring this webinar kindly. I'd suggest you all stay tuned until the very end because Anne-Marie from Kin will hopefully be giving away a hamper at random from the 21 member of the audience. So yeah, stay tuned for that. So before I present the speakers, I just want to run through really quickly through a few housekeeping points here. So I'd say most of you now are well versed in the world of Zoom at this stage. So this is probably null and void, but I just want to be sure everyone's comfortable. So feel free to ask questions throughout the webinar. We'll choose a handful at the end and ask them to each of the presenters. And then I'd also highly encourage you to engage in the chat function of the webinar. You can see all these options at the bottom of your screen usually. So, you know, just to share your experiences and thoughts and in dealing with the management of obese patients in your practice. And you can also raise your hand at the end if you wish, if you want to vocalize your opinions or thoughts or questions. I can ask you to unmute your mic and then we can have a conversation that way. And the last thing is many of you will see a closed caption down at the bottom of your screen. You can move that, you can turn that off, you can turn that on. It's just helpful for accessibility purposes. So with that out of the way, we have first Dr. Gillian Howie, who is a consultant in special care dentistry in Northamptonshire Healthcare NHS Foundation Trust. She's been working with an increasing number of obese patients requiring treatment under sedation and general anesthetic, and has recently published a paper in the BDJ on this very same topic. And I'll link it in the chat after the presentation. And our second speaker is Dr. Alison Lang, an SPR in special care dentistry, also working in Northampton. And she's previously worked in Max Fax earlier in her career, then spent a few years working in community dental service before starting her specialty training. So, Alison, without further ado, I would like to hand the stage on to you, if you don't mind.
Perfect. Okay, lovely. Thank you, Ahmed, for that introduction. So my name's Ali, as we've already said. I'm the new SDR in special care dentistry in Northamptonshire, and tonight's webinar is going to be discussing bariatric dentistry. So the term bariatric is derived from the Greek word baros, meaning weight, and iatric, meaning treatment. So it's the study and treatment of obesity and diseases experienced by the overweight. Dental care for bariatric people may require special dental equipment, and access to dental services may be more difficult if the level of obesity has impacted on mobility and health. Not sure why I can't, there we go, just a bit slow. Looking at this slide here, there's some news headlines on bariatric dentistry that I just want you to have a brief look at. And on the right-hand side of your screen, you will also see the intraoral dental slim device, which is a newly developed device that dental professionals are to fit to try and reduce obesity. So it's just interesting to show you this recent development. So the learning outcomes for my section of the webinar is to appreciate the demand for special care dentistry for the increasing bariatric population, and to acknowledge the challenges for dental staff who are going to be treating bariatric patients under local anaesthetic. Okay, so obesity is a global problem. And looking at this European map of obesity figures, you can see that in Ireland, 25.3% of the population are obese. And in England, it's just under 28%. In Ireland, a further 37% of the population are overweight. And in England, this is 32%. The Lancet Project 2016 predicts that by 2025, Ireland will have the highest figures of obesity in Europe. Obesity will impact the individual by increasing chronic diseases, causing psychological concerns and a reduced life expectancy. We also note in these COVID times that the obese population have been more disproportionately affected. So there's been more hospital admissions, more cases in ITU, and more people dying compared to the non-obese population. And it's not just the individual who feels the cost of obesity. So within England, it costs the NHS approximately £6.1 billion per year, and a further £24 billion for the wider society. And I've just put on there the graph that just shows in Ireland, 4.6 billion euros is spent on bariatric patients, and per person who is bariatric, their whole lifespan is costing 16,000 euros. As I have said, obesity is a major public health problem, and there are obesity correlations with different demographic groups, which is shown here. So firstly, looking at age, in both England and Ireland, as you age, obesity increases, and this is true up until the 75+ age bracket. Your socio-economic status can also affect your risks for obesity. So it's known that as the index of multiple deprivation increases, so does the obesity levels. If you're disabled, you're more likely to be at an increased risk of having obesity, and also dependent on where you live, this can affect your risks of being obese. So in England, the North East and West Midlands have the highest levels of obesity. And in Ireland, it's the people living in the border regions, such as Counties Cavan, Donegal, Leitrim, Louth, Monaghan and Sligo, who are most likely to be overweight or obese. So how do we calculate obesity? So we commonly use the BMI, or the body mass index scale, which is your weight over height squared. But does this accurately represent somebody's adiposity versus their muscle mass? And is it a true representation? Certain ethnic groups, pregnant women and athletes or bodybuilders don't fall in that BMI tool. Patients may also not know what their weight is. You can refer them to the GP or a dietetic clinic where they might have a bariatric or a wheelchair scale. A more rudimentary measurement in the clinic could be if you get 2 standard weight scales, and if a bariatric patient places a foot on each of these, you could add the total up, but again, it isn't going to be that accurate. You can also use somebody's mid-arm upper circumference, or the mid-upper arm circumference, to gauge their weight. And if they don't know the height, you can measure the ulnar length. And the graphs here just show the WHO classifications for BMI for adults. This just shows the associated comorbidities alongside obesity. With the BMI tool, you can look at somebody's weight circumference, and this will tell you about their central abdominal obesity, which will give you additional information on the risk of developing one of these associated conditions. This is an obesity systems map, and it looks at the roles of both the environment and the individual and the factors at play when we're trying to reduce obesity. The drivers of weight gain are poor diet, reduced physical exercise, and the susceptibility of different individuals on weight gain. And this map looks at our whole systems approach to tackling the bariatric population. So I've already noted that patients with a disability are at an increased risk of being overweight. So why is that? They might have an underlying health condition, such as Down syndrome, Prader-Willi syndrome, or hypothyroidism. They may have mastication difficulties or dysphagia following a stroke or a brain injury. Some of the medications that they take may predispose them to weight gain, so such as steroids. They may have a physical disability which may limit their movement, so it might be painful if they've got arthritis, or they might be immobile if they've got spina bifida or cerebral palsy. I just thought it was interesting to note that on the guide for commissioning dental specialities and the special care dentistry for England, on the front page it depicts a bariatric special care patient. So what is being done to tackle obesity? So there are multiple public health initiatives such as the Better Health campaign, the Change for Life, and in Ireland, the Healthy Weight for Ireland plan. They've also introduced in 2018 the sugar tax levy for England and Ireland. So if products have a higher sugar content, you pay a higher price for them. There's also been a ban on advertisements of salty, sugary and fatty foods before 9 o'clock, both online and in TV. And there's often calorie labelling now required in larger restaurants. This slide just shows the public health strategies in England across different governments and what they're doing to tackle obesity. And I just thought, looking at the trends, are they making a difference? It doesn't suggest that they are. In terms of weight management, there's a tiered treatment approach. So starting at the bottom, simple commercial weight loss programs, dieting improvements and physical activity. You then move up a stage to lifestyle management by having dietitian input or CBT. Alongside this, there is pharmacotherapy, so medications that can be given alongside behavioural changes. So these are things like orlistat and liraglutide. These are really effective for patients or needed for patients with a BMI over 30 or 27 and above, but they have to have an associated comorbidity. Bariatric surgery is often the last resort and again is adjunctive to behavioural changes, and the choice of treatment is very much dependent on the patient's level of obesity and the risk of their associated diseases. So just some statistics for you. Between 2019 and 2020 in England, there were 6,000 to 7,000 bariatric surgery procedures carried out. In the same year in Ireland, there was merely 154. And the HSE states that in Ireland, it has the lowest level of bariatric surgeries in the Western world. I do know that in Ireland, there are often BMI weight limits for general anaesthetics, which does force patients to move further afield in order to get their bariatric surgery. So looking a bit more closely at bariatric surgery, the indications are severe obesity. So if a patient has a BMI over 40 or a BMI greater than 35 and a significant associated comorbidity. They have to have tried the non-surgical management techniques. They have to be psychologically stable with adequate social support. They have to be committed to long-term follow-up plans. And they also need to have a low operative risk. So they need to be able to survive the general anaesthetic and be well enough to have the procedure. There are 3 main types of procedures here shown on the slide. So the first one is gastric bypass. This is when a small pouch is created in the top part of the stomach and it's directly connected to the small intestine. The second is the sleeve gastrectomy, and this is when a large proportion of the stomach is removed, so it leaves a much smaller area than there was before. And the last is a gastric band. This is when a band is placed at the top part of the stomach, again creating a pouch. And this is often connected to a device that can be tightened. So in terms of treating the bariatric patient, I've come up with 5 aims. Firstly, you need to be able to maintain dignity for that patient. So appropriate triaging, sending them to the right clinic with the right equipment and the right people to see them. So there's no embarrassment when they get there. For example, are the doors wide enough to allow them to access? You need to be aware of underlying medical conditions that contribute to a higher BMI and also the medical conditions that are associated with being obese. We know that patients who are obese tend to attend a lot more infrequently because of the access issues that they are struggling with. So you need to be thinking about that when you're managing the patient and being realistic in their treatment planning. And also in the back of your mind, you need to be thinking, how far is this patient travelling to come and see you? And is there anything you can do? When looking at risk management, you need to be thinking of patient and staff safety. You need to be thinking about physical manual handling and operating positioning, and this should all form part of a formal risk assessment. And we also need close wide team working, so with allied health professionals trying to gather as much information in order to keep that patient safe when you're there in your dental clinic room. And it is also appropriate for you to refer patients for weight management solutions with their GP or a dietitian. In terms of the oral health implications when treating the bariatric patient, due to their immunological status and comorbidities such as diabetes and cardiac disease, there may be an increase in periodontal disease. Alongside this, they will have a reduced immune function and therefore poorer wound healing. Due to their lifestyle choices and diet choices, they may have a higher cariogenic diet and therefore have an increased risk of caries. Similarly, their diet choices and also comorbidities may increase the risk of them having gastroesophageal reflux disease, which can obviously cause tooth surface loss. This is also a common side effect of gastric banding. There is a potential for coagulation abnormalities if they were to have any comorbidities such as non-alcoholic fatty liver disease. And we know that obese patients have an increased risk of tooth loss. This is a bit like a chicken and an egg situation. We're not sure whether patients who lack teeth therefore struggle to eat and have to have a softer diet and therefore become obese, or are the patients obese, their diet and comorbidities mean that they're increased risk of caries and periodontal disease and therefore they lose their teeth. What we do know is that there are multiple barriers to them accessing care, and also when they are seen in the dental clinic, there's often reported poorer healthcare behaviours towards them. So looking at the environmental considerations when assessing these patients, you need to think initially, are they able to leave home? So can they access the dental clinic directly? Some patients with a BMI over 50 may be housebound and therefore require specialist care and support at a domiciliary setting. Or if they do need to attend clinic, this might have to be arranged via an ambulance stretcher transport to do so. When looking at manual handling considerations, I've already noted the formal risk assessment. So need to find out if the patient is able to walk, or if they use a wheelchair, or if they need a wheelchair when they're in clinic. Have you got a suitable bariatric wheelchair to support them? Do they need hoisting? And if so, does your hoist have a high BMI weight limit? You can see on the screen here, this is the bariatric chair that we have within our service. And there is a table that shows the different weight limits for different dental chairs. So just ensuring that you know this, and really it should be displayed in your clinic as well. I've also put on here about the operating tables in general anaesthetic, just so you're aware that there are obvious weight limits for those too. When looking at facilities that you have in the waiting room, you need to make sure again that the chairs have a high BMI weight limit, and often they should be armless to allow the patient to sit more comfortably. Thinking about the toilets that you have, are they also able to support a bariatric patient? And it's just worth noting that a standard toilet has an upper limit of 226 kilos. Are you going to be providing any clinical holding to your patient? It's unlikely that that's going to be feasible due to their waist circumference. It's going to be much more challenging. So for some of your special care patients that are of a higher BMI, you're going to think of alternatives with managing them. And in case of a fire, do you have a fire safety evacuation plan or a PEEP, so a personal emergency evacuation plan in place for these bariatric patients? I know that in Ireland, I understand that there are quite a few limited bariatric chairs, and these are often only accessible for medical card holders. And as I've already noted, that the GA service is often limited for the bariatric patients. When looking at operating challenges, firstly, anatomical landmarks may be lost. So, for example, when you're delivering your inferior alveolar dental nerve block, the fatty deposits that are there may make it more difficult for you to use a conventional technique. So you may need to adopt the Gao gates, which is where the local anaesthetic is meant to be delivered at the tip of the condyle, or using an Akinosi closed mouth technique. Similarly, the retromolar pad region and the increase in soft tissue may mean that denture construction is a lot more challenging for you. You need to carefully manage your soft tissues, and this is when your assistant can become really, really helpful, using a second mirror or a lax retractor in order to provide access for you when you're completing any restorative work. Because of the soft tissue proliferation, again, intraoral x-rays are going to be really challenging, and the patient may struggle to actually fit within the OPT machine if you have one. So you may need to try lateral oblique x-rays, and you can see on the slide here, there's just an example of that. When looking at your patient positioning, you're going to struggle to recline the chair fully. Because of the weight distribution, it will lie on their chest and therefore cause breathing difficulties. So it's much better to treat that patient standing upright, but again, that's going to have problems for the operator, and it's going to long-term cause musculoskeletal issues. So you'll need to adopt a good stable core. I think it was discussed in the recent ergonomics webinar around this. Your procedure length might be limited, so not just because of operator fatigue, but you need to be conscious of leg edema, cellulitis and pressure sores that may occur if the patient's in the chair for a long, complex procedure. So again, realistic treatment planning for these patients. So in terms of managing a medical emergency, I would have a much lower tolerance to call 999 and get additional support when managing a deteriorating bariatric patient. So the monitoring equipment that you have available, such as the blood pressure cuff, you would need to get the bariatric size, which is up to 45 centimetres. And if that isn't large enough, you can use a thigh cuff. The intramuscular needles needed to deliver emergency drugs is going to need to be a lot longer to get through the fat layers. The airway management may be compromised and may be more easily lost, and Jill is going to discuss that in greater detail in the second part of the webinar. If the patient was to choke, your abdominal thrusts are going to be a lot more ineffective, so you want to focus on really good quality back blows. And if the patient did become unconscious, in terms of CPR, it's going to be a lot more challenging. Again, your anatomical landmarks are lost, such as your xiphisternum. Also, physically getting over the patient to deliver good quality compressions, and also the weight that they carry in order to do that is going to be a lot more limited. There are bariatric CPR boards that you can buy, and I recommend if you're treating bariatric patients to support this. If the patient was conscious and needed placing in the recovery position, that's going to take multiple members of your team. So just ensuring that there are other personnel available in your clinic to support should you need. And again, this should be part of your risk assessment. And when looking at a bariatric patient with an oral or dental infection, you need to be very careful when assessing for any extra oral swellings, because these may well be hidden. So for example, a Ludwig's angina, you may struggle to diagnose that, and obviously the patient could become extremely unwell. So finally, just looking at the legal frameworks that govern us as professionals to ensure that this bariatric patient is treated appropriately in our clinics. So the Equality Act and the Disability Act state the need for reasonable adjustments. So if you're in a dental practice, perhaps, where you only see a handful of bariatric patients, you wouldn't be expected to get all of the bariatric equipment, but you should be able to refer that patient to a service that does. And if you are a service that has bariatric patients, then lots of the things that I've mentioned should be in your clinic. The Health and Safety at Work Act state that you should operate in a safe environment, and the Unfair Contractual Terms Act state that even if a patient is aware of the risks of using a using equipment outside of the manufacturer's limits or recommendations, it would invalidate the dentist's public and employee liability insurance. So what that means is, if you had an emergency bariatric patient that came in and the only dental chair you had available, the patient exceeded the weight limit for, if they were happy to accept that, it doesn't matter. You would still be accountable if something went wrong and that chair couldn't support the patient. In England, the GDC has 9 standards, and the first standard is to put the patient's interest first. The GMC states that first you should do no harm, and the Dental Council in Ireland states that you must maintain the safety and welfare of your patients. Thank you everybody for listening. I think we'll be answering some questions at the end. Here is just a list of my references, and I'll be handing over to Jill now, who will be carrying out the second part of our webinar tonight.
Thanks very much, Ali. That was an excellent presentation, really enjoyed it. And before I start, I just want to say sincere thanks for the invitation to present this evening. So the second part of this webinar is going to focus on the provision of intravenous sedation with midazolam for obese patients. And this is my particular interest in this topic was sparked during my time working in this building here. So this is Birmingham Dental Hospital. And the demographic changes that Ali has mentioned in her presentation were very much reflected in our incoming referrals. And that meant that within the special care department, we were seeing patients with complex medical conditions who were obese, patients with severe mental health problems who were obese, patients with a learning disability who were obese. And initially we would explore inhalation sedation, but in some cases that wasn't sufficient for the behavioural management or the anxiolysis that these patients needed. And so we began to think that we wanted to explore how we might have an assessment tool or some management strategies that would allow us to offer this type of care safely. Because ultimately we wanted to avoid using general anaesthetic if we could for these patients. So following on from that idea, risk assessment, both formal and informal, is a huge part of all our professional lives. And it's crucial in managing these patients safely. But what we can't afford to do is to use that risk assessment as an excuse or a reason not to treat, because ultimately, particularly within special care dentistry, we're in the business of managing risk. It can't be eliminated. So within those safe parameters, we must remember that. Now, where we draw the line as to what constitutes a risk that's too great to take is going to vary depending on a number of patient factors and operator factors. And it's also likely to change over time. So as we've seen from Ali's presentation, 30 or 40 years ago, when obese patients made up a very small cohort of those we were seeing, this might not have been a priority. But we no longer have that luxury. And I think this is something that we need to explore together to think about how we can deliver safe dental care for these patients. Now, my disclaimer here is that I'm not advocating that you all go into work tomorrow and start delivering IV sedation with midazolam to this ultimately very complex cohort of patients. But what I do hope is that over the next 20 minutes or so, I'll give you some food for thought, and maybe as a profession together, we can come together to think about how we might move this forward. So I'm going to go through each of these points in turn. These are the 8 steps to safe sedation for obese patients. So first up, the decision to ask a patient to starve before IV sedation is one that the IACSD outline as being controversial. And their guidance tells us that any practitioner should be able to justify their choice either way. Now, in relation to obese patients, there are a few specific considerations as to whether it is necessary to take these steps to minimise that risk. So we see an increase in abdominal pressure, and that's because of the weight of the adipose tissue pushing down on the abdomen. But interestingly, high BMI is also associated with a reduced pH in the stomach and also reduced tone of those sphincter muscles at the top of the stomach, and therefore a risk of hiatus hernia, even before we talk about the potential bariatric surgery changes. Now, despite that, the increased risk of aspiration of stomach contents is largely a theoretical one. But if we can balance the patient's other risk factors, and that might be blood sugar levels for a diabetic patient, for example, then it is thought wise to minimise these stomach contents before sedation. Now, the most common approach to minimising these contents is using the 2-4-6 starving rule. So asking the patient to avoid even light foods for 6 hours before the procedure, and reduce no intake of any clear fluids for 2 hours before. Now, in regards to other steps that we might take, there have also been a few studies that have looked at the use of prophylactic proton pump inhibitors, but they haven't been found to be of any particular benefit. But what is really interesting is that the most common cause of a chronic cough is actually undiagnosed reflux. So if a patient presents with that chronic cough, it's a very good idea to get them to go and see their general medical practitioner so that they can be medically optimised before we start any elective dental treatment. The next step then is looking at patient positioning. So this is something that can make a huge difference in terms of physiologically optimising these patients. So when someone's reclined in the dental chair, the weight of that adipose tissue that we've mentioned is pushing down on the chest, and that makes it more difficult for them to inflate the lungs. So if we think of the lungs as the balloon in this picture, essentially what an obese patient is having to do is to inflate that balloon with the brick on top of it. It inherently takes more effort. Now, that supine position also reduces something called the functional residual capacity, or the FRC. So if we think of the balloon analogy, again, the way I like to think about this is if you take a new balloon out of the packet, you have to use more effort on that first blow to get it started, and thereafter it becomes a bit easier. It's a similar principle in the lungs. We don't want to empty the lungs completely of air after each blow, or else we'd have to use that additional force each time we took a breath. Now, to reduce that increase in effort that's required, the literature suggests that we've got this optimal positioning that we can get our patient into. And this is the ears in line with the sternal notch. And what we've done here is taken a picture in our dental clinic. So this is a patient on a design-specific bariatric bench, and it shows how this schematic diagram might translate clinically. And we've heard from Ali already how there is always an element of compromise in regards to patient positioning, because the operator preference and their musculoskeletal health will have an impact, but also depending on what tooth we're taking out, we want our patients in different positions. So the next consideration is the selection of the team that we want around us. Now, as we all know, in dentistry, we practice conscious sedation. But the reason for much of the risk assessment that we carry out is that at the end of the day, sedation is a continuum, and we need to be safe in the knowledge that we would be able to manage that airway if we were required to do so, despite doing everything we can to prevent putting our patient and ourselves in that position. Now, there are several factors that make airway management more difficult for obese patients. So first of all, Adipose tissue will deposit inside the body in just the same way as it does outside the body, where we can see it. And what that means is that in the airway, the lumen through which air can travel is reduced, and a narrower tube is likely to occlude or collapse more easily. The other factor that's worth mentioning is that metabolic rate is proportional to body weight. And so in obese patients, when that airway occlusion does happen, the oxygen stores are used up much more quickly, but carbon dioxide is also produced more rapidly. Now, all of that altered physiology leads to a reduction in something called the safe apneic period, or SAP. And that's the time between apnea or obstruction and oxygen levels starting to fall. And the reason that it's so important to us clinically is that this is our thinking time. This is the time we can take to perform airway maneuvers or to give additional oxygen, for example. Now, the final aspect of this perfect storm, if you like, is that the action that we might then take to improve that airway is inherently more difficult. So in obese patients, we often see glycosylation of the cervical vertebrae, and that's particularly if they have type 2 diabetes, but they also often have excess tissue at the back of their neck, and that would make a head tilt much more difficult or maybe even impossible. In regards to ventilation with a bag and valve mask, we have that increased weight on the chest that's going to reduce the lung compliance and make it more difficult for us to ventilate that individual. So because of all this, we have to select our A team for appropriate airway management. And that might mean a number of different things depending on where we're working. So it might be that we want a separate operator and sedationist so that those individuals can focus entirely on one task. It might mean that we want 2 sedation trained nurses that are familiar and comfortable with airway management. Or it might mean that we do some scenario training with the team in the clinic that day so that we can allocate airway management duties, and that allows us to respond much more quickly and efficiently if we have to. So those of us who provide IV sedation, I'm sure, will be able to instantly recall that sense of dread when you look at an arm and a hand and you can't feel a vein and you can't see a vein. And I think, although we all know that obese patients are more difficult to cannulate, we need to go back to basics here. Let's keep it simple. Have we tried all of these simple measures? Have we immersed the patient's hands in hot water? Have we asked them to sit in the waiting room with some insulated gloves and some heat packs in them? Have we used a really effective tourniquet with the right level of pressure to get these veins to stand out? And have we used really robust percussion to get those veins to stand out to us? Now, in the event that these measures aren't successful, technology is developing, and we now have access to things like infrared vein finder technology. And although I think it's more common in hospital settings, ultrasound technology. And that ultrasound technology depends on the amount of adipose tissue that's sitting over the vein. And what I would say in relation to these new pieces of equipment is that it's a very different skill. It looks and feels very different to that cannulation that we've spent years trying to refine. So if we've got access to these, it's a good idea to have a practice on them. The next step to think about is supplemental oxygen use. So the potential benefits of supplemental oxygen use are quite clear. If we've got a group of patients here who are going to desaturate more rapidly, then making sure that all of the hemoglobin molecules are at their optimal saturation before that starts to happen is going to be a good thing. But there's always some debate around the use of supplemental oxygen, and in particularly whether it can do any harm. So to consider any potential risk in using this oxygen, we need to introduce a few ideas that are specific to obese patients. So bear with me for the next few minutes, it will all come together. Sleep disordered breathing. So this is a spectrum of disease. We've got obstructive sleep apnea at one end and obesity hyperventilation syndrome at the other. And as most of us will know, sleep apnea is a condition where during sleep, the airway partially obstructs and that causes a snore. And then the airway will fully occlude so that there's no airflow at all for around 10 seconds. And we classify it as mild, moderate and severe. And in severe obstructive sleep apnea, these episodes of complete cessation of breathing can happen up to 30 times in an hour. Now that leads to a really chronic hypoxia and a plethora of health problems. At the most severe end of the spectrum, we've got this obesity hyperventilation syndrome. And that's where the OSA problem occurs, but the body can't compensate anymore. And so we end up with a hypercapnia, high levels of carbon dioxide building up in the body. And that's not simply restricted to nighttime, it now begins to extend into the day. Now, these patients can develop a distinctive physical appearance, and it's that of the Dickensian character, Mr. Pickwick. And the condition is therefore also referred to as Pickwickian syndrome. Now, it is quite rare. Only about 10% of people who have obesity, and it is normally morbid obesity and obstructive sleep apnea, will go on to develop obesity hyperventilation syndrome. But it is serious in many ways, and it often goes underdiagnosed. So why have I gone to the effort of explaining this condition? Well, really, because the pathophysiology of Pickwickian syndrome is often compared to that of type 2 respiratory failure because of that hypercapnia. And so for this small subset of patients, oxygen therapy should be avoided because it might cause harm over an extended period. Basically though, these patients are not suitable for sedation in primary care, and not only should they be seen in a medically supported setting, but they should also be seen alongside an anaesthetist. So the next logical question to ask me is, well, how do we identify these patients if they often go undiagnosed? And you might think that that would be challenging in a dental clinical environment where we don't have access to arterial blood gas testing, for example. But actually we can rely on a thorough clinical history and identifying clinical signs, as well as having a sensible threshold. So these patients will present with really excessive daytime sleepiness. Their oxygen saturation will be below 94. They'll have extreme shortness of breath when we question them, and that would just be on minimal exertion. And we also see the physical signs of pulmonary hypertension and right-sided heart failure. So an increased jugular venous pressure that we might see as pulsing on the side of the neck, or that pitting edema or ankle swelling. And alongside that, some facial flushing is also seen too. Now, lots of those signs that I've just listed, we would all assess as part of a thorough medical risk assessment prior to sedation. And I hope that we would identify a patient that ticked these boxes as being at significantly increased medical risk. For the other patients, however, who don't fall into that subset of those who potentially have Pickwickian syndrome, what we did was we looked at the literature for an answer as to whether supplemental oxygen would be of any benefit. And there's quite a poor evidence base around this in dentistry. But cardiology and gastroenterology units see huge numbers of obese patients for investigative procedures under sedation. And so they've got great data sets from this sort of thing. And that gives us really super transferable literature from our colleagues there. Now, some of that research is in relation to deep sedation, so it uses multiple drugs, etc. But overall, there are some useful similarities. And this tells us that during sedation with benzodiazepines, hypoxia in obese patients is reduced when we use supplemental oxygen. And not only that, but oxygen increases the time from obstruction to desaturation. And that's this safe apneic period that we were talking about. And it also reduces the risk of cardiac ischemia. So on the whole, as long as we identify and exclude that small subgroup, which is relatively easily done, then oxygen seems to be a helpful adjunct. And my last caveat here is that when we use oxygen, as we know, we have to be incredibly cautious in monitoring a patient's ventilation and not focus entirely on the oxygen saturations, which can be misleading when we're oxygenating a patient. And that leads me nicely on to the discussion around capnography. So I'm sure many of you will be aware capnography is the monitoring of the concentration of partial pressures of carbon dioxide in expired respiratory gas. So it's useful because it tells us about ventilatory rate and it helps us to overcome those challenges of inaccurate readings on a saturation probe. As we know, a SATS probe tells us about the saturation of hemoglobin molecules in the blood. And so when we give additional oxygen, that might well read as 100%, but if the patient isn't moving air in and out of their lungs, then it's not doing them any good. So this is perhaps a useful addition to the oxygen saturation readings and the 10-minute blood pressure readings that we would routinely take. Once again, there's not a lot of literature within dentistry, and the literature that is there looks at using capnography for patients where we give sedation when they're healthy and we don't use supplemental oxygen. So again, if we look at the transferable literature from gastroenterology and cardiology, we can see clearly that when we start talking about obese patients and that altered physiology that we've discussed this evening, and if we ensure that supplemental oxygen is being given, then the capnography does in fact detect desaturation and apnea much more accurately and much more rapidly. And again, there are advances in technology. So now the nose pieces that we would use are much less intrusive. And so much neater piece of kit that can sit on the end of the nose, and something like this would deliver that supplemental oxygen at the same time as reading producing the capnography readings, and it helpfully doesn't get in the way of the mouth. Which at the end of the day is why we're doing this. So it's really out with the scope of this presentation to cover all the airway assessment tools that you might be using in your own places of practice. But I think that there are a few key questions that we should all ask ourselves before we give a sedative or a muscle relaxant drug. So first of all, can I control the airway for this patient if I need to? And secondly, can I oxygenate or ventilate the patient if I need to? And the thing here is that there's no one tool that's been shown to be particularly sensitive in predicting that difficult airway. But if we use a combination of bedside tests, then it can give us a really good insight into what might be challenging. There are some recurring themes though. So with airway management, that's going to be affected by neck and jaw mobility. Difficult bag valve and mask will be influenced by the presence of facial hair or an edentulous state, so that we can't get such a good seal with that mask. The ability to oxygenate is going to be affected by lung compliance. Now, that might be reduced because of an underlying respiratory disease, or it might be reduced because the patients had radiotherapy to that chest area. And this document in the top right-hand corner of the screen from the Australia New Zealand College of Anaesthetists, I found a great summary of all of these bedside tests that are available. So I would recommend that you have a look at this where they're all outlined very clearly. Now, the test that is very well validated, particularly for obese patients, is the Stop Bang assessment tool for sleep disordered breathing. And so it's highly recommended that we use this when we're assessing patients and trying to identify those that might be of higher risk. So it's quite a simple screening tool. It looks at the presence of snoring, daytime sleepiness, cessation of breathing, high blood pressure. It looks at high BMI, at age, neck circumference and gender. And then we allocate an overall score above which the risk of sleep apnea becomes greatly increased. Now, just as an aside, there are a few studies to suggest that patients who have been diagnosed with sleep apnea and are already using a CPAP machine might find it useful to use that CPAP machine in the post-operative recovery phase. So clearly we can't have a CPAP machine on while we're doing the dentistry because that would impede our access, but that might be something that's worth exploring in that post-operative phase. The final of the 8 steps then, we need to think about allowing some additional time for recovery. So midazolam is a lipophilic drug, so it's fat-loving. And so when we administer it to an obese patient, it's going to bind to those fat stores, and where it's bound, it's not going to be active in the plasma. And that often means that we have to give a higher dose to reach that desired sedative effect, but it also means that we have to allow the patient a bit longer to recover and have that drug metabolized. There are lots of great things about midazolam as a drug for this cohort of patients though. So in dentistry, we use a titrated dose, so we avoid that empirical dosing regime. We always have a reversal agent on hand, which is great news. And last, but by no means least, obesity is a risk factor, as we've heard this evening, for adverse cardiovascular events like myocardial infarction. And so IV sedation with midazolam is a tool that's going to reduce that sympathetically induced stress response and make the dental procedure safer ultimately for the patient. So I hope I've given you some considerations for managing this group of patients. My summary is that it's never clear cut, I'm afraid. Instead, we have to think about a whole host of factors that influence the management of these patients, as well as their comorbidities, which ultimately are often wide-ranging and underdiagnosed. The whole dental team is absolutely crucial in these cases because airway management is inherently more difficult, and the decision to treat a patient should always be heavily influenced by your own experience, your qualifications, and the setting in which you're working. And always remembering in the background there that picture of Mr. Pickwick, and reassuring yourself that with thorough clinical assessment, we should be able to decide where the best setting or the best place for these patients to be managed is. Essentially, we don't yet have a protocol for IV sedation with midazolam for these obese patients, and some research would be incredibly useful so that we can have some sort of evidence base for the suggestions that I've covered this evening. So there's quite a few references, as you can imagine. All the references are outlined in the paper from the BDJ that was mentioned at the start. So that's probably the best place to go if you would like to see any of those in more detail. And I'd like to thank you very much for your kind attention. And Ali and I would be happy to take any questions.
Fantastic. Thank you very, very much. Thank you guys, Ali and Jill. That was amazing. That was super enlightening and actually very thorough considering the very short space of time that both of you had. you've somehow managed to incorporate quite a lot of information into it. So that was wonderful. We have a sleuth of questions coming through. So I will kind of start it off. There was an interesting conversation with a few people in the comments about the difficulties that people are experiencing with referring obese patients, specifically to dietitians. So I suppose I might start with you, Ali, and if, Jill, if you have any questions, or if you have any additions to that, if you just to kind of describe to us the relationship that you have with your dietitians in your local area, and if there's a referral pathway available.
So where I previously worked, it was similar to where I work with Neil Martin. So there is a clinic with dietitians there on site, so you can sort of get informal advice from them. In terms of a formal referral process, it would probably be via your GP, I would assume, Jill, as opposed to directly in England linking in to the dietitian. But most patients that are classed as being obese, if they haven't already had a weight management referral, that would be quite unusual. And the only sort of cohort of patients are the special care patients, really, that sometimes are undiagnosed. I know that we would see them, but really tapping into the GP as opposed to a direct referral to the dietitian.
Right.
The community clinics offer really invaluable sort of informal conversations, but a formal pathway would be, in your first instance, the GP. Okay,
thank you. I have another question for Jill this time. Jill, Simon asked a question: is there a role for perioperative CPAP with obese patients?
Yeah, so that's a really interesting question. There's very little evidence, and my mention of post-operative use of CPAP was really just a fleeting mention in some of the literature. I think perioperative CPAP, clearly there are different types of CPAP machine. So CPAP machines that will cover sort of nose and mouth, which would be inappropriate for use during attempted delivery of dental treatment. But there are also CPAP machines that sit below the nose, and it's whether there would be a place for them perioperatively. My thoughts on that is that if a patient is going to undergo sedation for dental treatment and they require CPAP to maintain or improve an airway, I wouldn't feel comfortable doing that in a purely dental setting. So yes, there might be a role for it, but I think for the patients that have a significantly compromised airway and would be better managed in a hospital with an anaesthetist. But it's certainly something to look at. And I suppose the other thing is it looks quite similar to, for example, a inhalation sedation when it's on the patient. And sometimes doing upper anterior work is difficult with that nasal hood on. And that's always in the back of my mind, that depending on what teeth we're working on, that might be a limiting factor. But I've no doubt that that's something that will be explored in the future.
Thank you. I have a question here from Laura. As a triager of dental referrals to a community dental service, there's often misunderstanding of referrers in the difference between overweight and bariatric patients. For example, a 23 stone 6 foot fit and healthy rugby player doesn't require special care dentistry services. Although being 23 stone means they are unsuitable for a standard dental chair, they aren't classified as bariatric. There's therefore a cohort of patients who fall into a gap where it seems no one is able to provide dental treatment for them. How are others managing? How are you managing this cohort of overweight rather than bariatric patients? Do you come across that often?
Ali, you might want to add to this, but our service in Northamptonshire, we don't accept referrals for purely anxious adults, for example. So our acceptance criteria requires that a patient needs that additional medical support or behavioural support to have care within our service. So I can appreciate that it must be frustrating for these individuals. I know that where I've worked previously, there was a role for the MCN where the MCN identified where the bariatric, the sort of higher weight limit chairs were available. And then we were able to signpost these referrers and therefore the patients to access that appropriate care, because clearly, we're a small service and we want to make sure that we're delivering care to those who really need us.
Thank you. We have a question from Dr. Alison Dougal. I'm just going to ask her to turn her microphone on now, if that's okay.
Okay. I haven't got any makeup on. Oh my God. Okay.
No, it's okay. Your camera's not seeing. It's just the audio, Alison.
Thank God. Good evening, ladies. Congratulations. I'm really delighted that ISDH are picking this subject again. I think, as this is my view, that people with who are overweight receive a lot of stigma and discrimination within healthcare. Yeah. And I think we can advocate for people. But I was interested, because this is something that I think people have challenges with. How do you talk to somebody when you're telling them that maybe they're too large to be able to offer them care, or that their care is limited, or they need to be sent somewhere else? Because I think that the language we use, or even when we're referring people to a dietitian, it's the sort of thing that people feel uncomfortable with. And I wondered if you'd got any tips for the audience, how you have a respectful conversation. What sort of words do you use? What sort of language do you use? That would really interest me with your experience with this group.
So I would definitely say that maintaining dignity, having those sort of direct, honest conversations, we are health professionals, and leaving out emotive language and simply stating that in order to treat you safely, there are parameters in order to do that, and that your BMI would exceed. So whether that was for sedation or the dental chair, but coming up with your solution, so not shutting the conversation and saying that is it. So having that knowledge that if you can't treat them, where can they go, so that they're not feeling stigmatized. So actually you can say, it isn't appropriate for me to see you in this environment because your weight does exceed. And I would keep it, Jill hopefully will agree, but keep it factual, and then just knowing where the appropriate place is for them to go, so they don't feel helpless and lost, and that you've just delivered news. And in terms of appropriateness for dentists with weight management referrals, it's asking those sort of directed medical questions. Who is involved in your care? Do you regularly see anybody? And trying to decipher that information potentially in the first instance without being too direct. But it is about treating the patient safely. And I think as special care dentists, we're very used to having difficult conversations or challenging discussions. So I do feel that we are best placed in sort of bringing up people's BMI and coming up with strategies to support them. And Jill?
No, I think that was wonderfully put. I think the other thing in relation to that that's interesting is, I don't actually have the reference to hand, but there have been a few studies looking at sort of patients' feelings about general dental practitioners taking more of a role in kind of preventative management. So where they have patients who come in who would have an increased BMI, taking that role of onward referral, whether that's to the GP or raising those, having those discussions with the patient. And I think often the feedback from those studies has been that patients would accept that type of input from dentists. And although I appreciate there is a stigma, And, you know, I think as Ali says, there's a safety issue. That's what we have to remember. But as she also mentioned, we are used to having these discussions where GDPs might not be so used to having those types of discussions. And so, you know, the sort of role of asking for advice so that GDPs can say, look, I've got this patient, would you be able to treat them? What are the options for their care? It is important. Thank you
very much, and thank you, Alison, for your question. I have, well, if we have time for one more question. So the last one is, have you found challenges in ensuring that you have all the equipment as needed with the sufficient maximum safe working weights? And if not, how do you overcome that challenge? If you have, how do you overcome that? And, you know, is there an option to refer to bariatric patients to anesthesiology or day service units in cases where they can't be managed?
I think that would very much depend on where you're working. I think the main challenges that I've had have been patients who require ambulance transport and also bariatric facilities. So I've been very lucky to work in clinics and hospitals where I haven't particularly struggled with access to this sort of equipment, but often ambulance transport will agree to bring the patient, but they can't, for example, leave the bariatric stretcher. So it's these special care, real exciting special care patients where there's not just one thing to think about. There's the social issues, the medical issues, they've also got an increased BMI, all these things coming together, and that's where the challenges present. But I think that's where working in a really great dental team is also important, because we've got an excellent dental nurse manager who's able to, you know, look at liaising with wards in the hospital, for example, where we might be able to use a bariatric bed while the patient comes in on ambulance transport. And I think having these close links with other departments and other healthcare providers is crucial, so that we can give that sort of holistic approach that's needed.
Fantastic. Thank you very much. Thanks both of you, Ali and Jill, for such an informative presentation and very, very good answers just to the questions. Everyone's always nervous about the Q&A, but that was wonderful. And thank you for all of our attendees who asked questions. So the last thing now is I would just like to ask Anne-Marie to say a few words. Anne-Marie is a representative for Kin Dental, who will hopefully be joining us shortly, and she will also be announcing the winner of the hamper as well. Anne-Marie, how are you?
I'm great. Thank you very much, Ahmed, and thank you, Ali and Jill, for a very informative and enjoyable webinar. As Ahmed mentioned, I'm a medical sales representative from PAMEX, and I work with Kin Dental, and I'm based here in the east of the country of Ireland. Ali mentioned specifically periodontal disease in obese patients, and PAMEX has a very keen interest in the area of periodontal disease. One of the ways that Kin is focused on periodontal disease is through our PerioKin Hyaluronic 1% gel, which is available in a 30 ml size, if you can all see it there, and also a 125 ml, which is an in-surgery size. This gel contains 0.2% chlorhexidine, which gives the product powerful anti-plaque properties and a high level of substantivity, which is ideal in dentistry for certain treatments and the prevention of infections. It also contains 1% hyaluronic acid. This 1% concentration is 5 times stronger than in any other dental gel, and therefore the speed of healing can be increased by up to 40% in the first 24 hours. The benefits of the 1% concentration is that it gives a potent healing effect, which moisturizes and gives greater viscoelasticity that increases the retention of the treatment area. The gel is 20% more adhesive than other dental gels, for perfect fixation on the area. And the indications are post-procedure usage of 1 to 2 weeks, oral hygiene in the case of post-surgery, post-extraction, implants, periocornitis, and scaling and replaning. We also have published scientific studies on the Periocaine Hyaluronic 1% gel. So in summary, Periocaine Hyaluronic 1% gel is a unique patented formulation that will greatly increase healing outcomes for your patients. We're also delighted to announce that Kin Dental products are now available to purchase in the UK. And if you have any queries, please visit our website, www.kindental.co.uk. And thank you very much for listening, everybody.
So thank you very much, Ali, Jill, and Anne-Marie for joining us. Thank you to all of our attendees. And yeah, have a nice evening. Thank you, guys.